before we get started, I just want to acknowledge that this has been a very challenging case from many perspectives. And the first is that Mrs. Murphey lost her life because of a medical error. And that's something that I think we should never forget, and that we should also keep in mind as we talk about the facts about this case and the really broad-reaching impact it's had on patients, families, and our clinicians and staff in our healthcare organizations, not to mention Ms. RaDonda Vaught, who was the nurse who was involved in this error. So before we get started, we're going to share just a very quick overview of the facts of the case as we know them, to kind of set the stage for our discussion. So on December 26th of 2017, Ms. Vaught mistakenly administered IV vercuronium to Ms. Murphey, who was preparing for an MRI in radiology. Charlene Murphey ultimately died, and Ms. Vaught reported her error to the treatment team when it happened and also participated in the subsequent investigation. On January 3rd of 2018, a few days later, Vanderbilt fired Ms. Vaught and later negotiated an out-of-court settlement with the Murphey family, but did not report the error to state or federal officials as is required. On January 10th of 2018, two neurologists at Vanderbilt completed Ms. Murphey's death certificate, classifying her death as natural due to a brain bleed, and the medical examiner did not investigate the case. In October 2018, an anonymous tipster alerted federal and state officials to this error. The Tennessee Department of Health did not pursue disciplinary action against Ms. Vaught and said the case did not constitute a violation of statutes or rule, and sent her a letter saying it did not merit further attention. The Center for Medicare and Medicaid Services, CMS, conducted a surprise investigation of Vanderbilt after the anonymous tip came in and found a long list of deficiencies which they required Vanderbilt to remedy. In February of 2019, Ms. Vaught was indicted for her role in Ms. Murphey's death and charged with reckless homicide. In July 23, 2021, the Tennessee Board of Nursing revoked her license. And on March 25th, 2022, Ms. Vaught was convicted of criminally negligent homicide with a potential prison sentence of up to 8 years. On May 13th of 2022, the court sentenced Ms. Vaught to 3 years probation with the possibility of having her conviction dismissed as long as she complied with the probation requirements. So this is a very quick overview of the background of what has happened. And now we're going to move to our discussion with Julie Morath and Sue Sheridan. So I'm going to begin with a question to Ms. Morath. And it's a question about a very core component of what this case may have done in many different arenas in healthcare. So can you talk a little bit about what trust is, what defines trust, what is the construct of trust that we should all be thinking about as we go through this discussion?
I think a helpful way to think about trust is with 4 questions. Do I believe the positive intention of another? Do I believe the competence and skills to depend on that other? Do I believe the benevolence and kindness of the other? And do I believe the integrity that they'll do what they should do, what their duty is, and what they say they will do? But it goes through individuals, teams, organizations, the oversight, our neighbors. Trust is a fabric of our relationships with one another, and many layers of trust are being challenged as we look at this case. trust between patients and their providers, trust between nurses and physicians, trust in healthcare organizations in that they could actually try to cover up an event, and trust of the public oversight and the public trust that's lost when there are these gaps that occur. Trust, and this is a key point in my view, is an antecedent to psychological safety. And a word about that is psychological safety is a cultural climate in which speaking up and reporting is a norm. The candor takes the place of silence, and engagement takes the place of fear, and in which learning and humility are values. And that sense of belonging that comes with being a part of a psychologically safe place gives us courage and conviction that we need to move forward for safer healthcare.
Thank you. I'm going to move to Sue Sheridan. And Sue, I'd love to hear from your perspective. I think we all would. What are the ramifications of this case for patients and families, and how has it affected people that have been deeply involved for decades in the patient safety movement and working on as patient advocates for safety across our healthcare system?
Sure. Thanks, Susan. Going back to the trust, the word trust, something that I think resonates more with us is trustworthiness. When we look at our clinicians and our organizations and our oversight organizations have they gained the trustworthiness? And that's the ability to be relied on as honest and truthful. And so when we thought about this case, and when I say we, I am part of Patients for Patient Safety US, a large group of patients and advocates. And we, like you said, we've been working for almost 2 decades on patient safety. And so I think the first reaction to the Vanderbilt and RaDonda Vaught case was one of lack of trust or loss of trust at the organizational level, to be honest. Our first reaction was this lack of truthfulness. One of our values is truth telling. And so we saw the lack of truth telling at several levels. The doctors who chose to say that the death was of natural causes, the fact that the medication error was never put in the medical record, the fact that, as you noted, that this was never reported to the state or federal authorities. So that reality for us was really quite shocking, that this continues to happen. I think we actually took it quite personally because many of us experienced that ourselves as patients when we lost loved ones, and there was cover up and there was denial and there was no report. So to see that this still happens today in large institutions, not just Vanderbilt. We know this is not uncommon to not report, to not have truth on the death certificates. That really was the most egregious acts to us. And so again, on several layers, and the fact that CMS knows about the fact that Vanderbilt didn't report, but we saw no real action by our oversight agencies on. So is this business as normal to be able to cover up, a death from an error? So these are all the reactions that we had. Now, another very big reaction was actually the criminalization of the event surprised us as patient advocates. We didn't think it was necessarily appropriate. Our biggest fear is that it'll drive, we know that there's underreporting of medical harm, but we're afraid this is going to drive it even more underground, where clinicians and workers in healthcare systems will be afraid to speak up and afraid to be truth tellers when there's harm from medical error. So all those levels, we really have, honestly, it's fractured our trust. We've been embedded in our healthcare system for a couple of decades thinking we've been making progress, and this has set us back.
Julie, how do you think, and what do you know about how this has impacted clinicians and other staff that work in healthcare, doctors, nurses, and other people that may potentially be involved in some sort of, harmful event?
Susan, I think it was jarring. It was, as Sue talked about, it was felt like a betrayal. If you think you're working in a place that is trustworthy and has psychological safety, and you yourself work at providing that, to see this happen has, I think, a very chilling effect on the profession. Because Ms. Vaught was a nurse, I think it disproportionately at this time probably affected nursing. But the idea that you could have a mistake affect a patient in a very tragic way, when there was not the safeguards in the system to prevent that mistake from ever occurring and reaching a patient, leaves question as to, am I next? Do I want to do this? It's a very difficult time for nursing at best, with the challenges that are out in the environment. And so I worry that we have an endangered workforce in healthcare, and that actions like this have set, as Sue said, set us back, I think, decades in the work we've done. I think one of the most toxic things that happens in healthcare, and illustrated in this case, is, as you walk through the timeline, Sue, is the decision, and it is a decision, toward protectionism. And that violates all the values that we hold and have been espousing and thinking we were making progress in patient safety. Now, when something awful happens, between the event and what happens next, there's a space. And we can either react with fear and distance and protectionism, and the impulse to run away, or we can choose to respond. And it's a choice is courage. Mm-hmm. And it's courage to lean in, to learn, and to create ways in which we can come together, rebuild our trust in each other and in the systems that we depend on, and that our patients entrust us with.
Susan, can I make one more comment?
Can you wait just a second, Sue? Because I actually want to make a comment, and then I'm going to come back to you.
Yeah.
But from my perspective, Daniel mentioned the work I've done around patient and family-centered care. For decades, when we go out and study organizations that have very high scores on their patient experience surveys, and we know they do a really good job, the number one attribute of all those organizations that they have in common is they are all great places to work.
Yeah.
You can't, if you're not taking care of your staff and they're not working in environments where they feel like they can deliver safe care, they can't take care of the patients in the ways that they came into medicine to do. So I just think that is a critical piece of this, and how we respond to it. But Sue, my next question, it may be something you were going to touch on, is we've only got a couple of minutes left before we open up for Q&A, and I really would like to focus on what do we know about the ways that organizations respond to events like this that actually enhance trust, create trustworthiness, both in their staff as well as the patients they serve. And Sue, I don't know if that was something you were going to touch on.
Yeah, I can certainly embed what I was going to say. It does include in that, and something that what would have been the best way to deal with this is, through a communication resolution program where the family was very involved, not just offered compensation and then sign a confidentiality agreement. And that's what I was going to talk about, trustworthiness.
Yeah.
Can we trust hospitals that pay patients to not share their story? That really worries us. So a CRP that would engage the family, disclose what happened, apologize, engage the family in creating new policies, and engage the family in knowing that, alerting the family that these have been reported to the various agencies. And so I think through a really solid communication resolution program, this could have been a much different experience, engaging the family along the way, and Nurse Vaught, and learning all together, implementing change all together in a very transparent way.
Yeah. Julie, I know you also have a lot of experience with communication resolution programs and sort of the impact they have in a lot of areas. I don't know if you'd like to add to that, or I also just want to make sure that everyone understands what we mean when we talk about communication resolutions program.
I think the communication resolution program in many forms, but we want a reliable, trustworthy one, allows us to be upstream and plan. Events should not happen. We need to prevent them. But when they do happen, we need something to mitigate that defensiveness and premature closure. It's when clinicians need each other and the families and patients need the clinicians. And the way we can find things to bring us together rather than separate us or turn it over to a channel of risk management and attorneys, and they have a place, but it's not to act as an agent that further divides people from each other in the caregiving relationship.
Yeah.
So you got to think about it in advance.
Sue, were you going to add something?
I was just going to add to what Julie said, is that, a program such as the communication resolution program that is upstream, it really enables the family to heal as well as the clinicians. And, when the walls come down and we don't get to participate in resolution and policy change, it prevents us from healing. It really does. And so I think that that's also something to add, that the CRP or this kind of approach is a remarkably healing process for all.
Yeah. And I don't know if either one of you would like to comment, but I think if you do, I'd love to hear your thoughts about programs like peer support programs, and think what we do to support staff that have been involved in some sort of event.
That was going to be a comment that I was interested in making, Susan. I think that when such things happen, they take a terrible toll on everyone, and that the well-being of our staff, as pointed out, is so critical for them to feel confident, competent, and have the discretionary energy to engage in the caregiving process and with one another. And in the absence of that, there's a sense of loss, abandonment, and fear.
Susan, can I add to that on the patient
Yeah.
side? Something that Patients for Patient Safety US and many of my colleagues in patient safety, we acknowledge that there needs to be care for the caregiver. But what we've seen is there's no systematic care for the patients and the families and the long-term needs that actually no one really knows about. The impact to my little girl when she was only 4 when my husband died, and the long-term emotional impact it has had on her and the family needs. And so when we talk about care for the caregiver, I really hope we can really generate and energize a movement in a systematic way to care for the family in a long-term way.
Sue, are you aware of any programs or any places that do that well?
I'm not, Susan, and that's something we've raised with some patient organizations. We had a great conversation with Leapfrog and their their hospital leaders about let's generate this dialogue about implementing a systematic way to ensure that all patients and families are supported. Now, there is a program in Boston, the MITS program, led by Lynna Kenny, that has some great resources. It's not widely implemented in terms of, especially for the patients and families. And I think it's assumed that we're, if we're compensated, we're taken care of, or if we get an apology, we're taken care of. And that does not address our psychological needs.
Julie, are you aware of any programs that do well from the perspective of patients or families that have been involved in an event?
I think there's really wide variation here. So is there a place that does this perfectly to the point that they prevent things from happening where you have to be having this dialogue? No, I think Virginia Mason, that's now part of Common Spirit, is one organization that has probably stood tall amongst peers in terms of 24/7 rapidly mobilized resources and being very open to the public when something does go wrong. And I think a key word here is accountable. I mean, this happened, it was on our watch. And carrying forth the memory of individual who had been harmed or died as a result in their care is a way of honoring and remembering and moving forward. And in all this, and to Sue's point, and I know your passion around the accountability is just spot on and rightly placed, is that when we talk psychological safety and trust, nowhere is there an absence of accountability. The expectation is people step up, show up, tell the truth.
Yeah. And that truth telling and transparency should not be optional.
Right.
And it is right now. And that is part of our loss and trust, that truth telling is optional.
I'm also going to ask people that are participating, if they have examples they want to add to the chat, that would be wonderful. And also encourage people to ask questions or make comments that you may want Julie or Sue to respond to or to comment on. And I see we have one about an event at Duke. I remember that. And they did do the right thing, and they did publicly talk about their error. I also remember a case that was really challenging many years ago at in Aurora, Colorado, with a hospital where they realized that they had operated on a patient with Jakob-Creutzfeldt disease, a brain disease that is contagious. And they had not sterilized the operating instruments properly, given that that was the problem the patient had. And they had used them on subsequent patients. And it's a disease that develops over time. And it doesn't just happen right away. And they went through a lot of soul searching about the impact of letting those patients know that they were at risk. And they ultimately did. And I think that was a very courageous and very challenging decision, but they told the truth. And I think that made a huge difference for how people felt about that system in that community. But
I'm sure there are many other examples as well. It's just
yeah.
Susan, I'm wondering if the audience, I see we have two more chats, but I'm wondering if the participants, what they think about when there is no truth telling. Should there be penalties? It's a good question. I'm curious about what the listeners think about that.
No response yet, but someone has talked about the peer support program. But I'm not sure if I understand. We also have a peer support program at Mass General that people can ask for help with. And it's interesting because I participate in that as a peer support counselor. And what's interesting to me is that many of the people that ask for help have actually not really been involved in a harmful event, but they're worried that they may have missed something. And they really want to talk about it, and they really want to get advice about how to manage how they're feeling and how to manage anything that they may need to do with their patients. There's clearly support for people that have been involved in a clear, adverse event. And we're seeing some comments that there should be penalties. And Sue, I'm wondering if you have thoughts, or if Patients for Patient Safety has recommendations or thoughts about, beyond what our regulatory agencies supposedly do in situations like this, if you have thoughts about penalties.
Well, I think our thoughts about penalties is given our structure that we have, with CMS, we would have anticipated some type of penalty, maybe financial penalty, similar to that of Consumer Product Safety Commission, in that if products are known to be unsafe and they're not reported, there is a financial penalty to that manufacturer. So we would like to see some meaningful financial penalties, honestly, to the organizations who choose not to report the truth. The Joint Commission and accreditors, we feel they should be more active when there is a failure to report, a death from a medication error, that there should be something that might threaten their accreditation. So I think there are ways that our current system could implement some penalties that may be meaningful. I don't know if it's been tried in the past, but if there are no consequences of not telling the truth, then it will continue.
I apologize for the light. The sun has come out in Boston, and I can't do anything about that. So I just want to go, there's a question in the chat about, was Vanderbilt fined? And we don't believe Vanderbilt was fined. I don't want to say that definitively, because obviously a lot of the facts around this case are not public. But we completely agree that it was unfortunate, and it's one of the reasons why we wanted to do this webinar today, that there was so much attention paid to the nurse and not to the responsibility and the accountability of the organization where this happened.
And Susan, just to let the participants know that Patients for Patient Safety US filed a complaint with the Office of Inspector General to investigate, so we can have a better understanding of what happened. I think the public deserves to know what happened. We deserve to see what our oversight agencies are going to do in light of all the facts that are known. So we filed the complaint not to punish Vanderbilt. We filed the complaint because it could have been anybody. We know that it could have been any hospital. We filed the complaint because we believe this is the practice that happens a lot with no consequences. So we, as a patient community, decide to dive in and request learning more about this, because we think the public deserves to learn.
Julie, you wanted
it was telepathy. I was going to say, one of the real tragedies, not that there's a single point of accountability, that I think is a big problem, but that all learning is truncated when people are not forthcoming. And if something happens within an organization on the East Coast, it should be known on the West Coast. I mean, this is how we start building the intelligence about giving us the ability to predict and prevent. So there's one part of responding that's absolutely critical, but the other is to learn from these tragedies so that we're not repeating them.
Right. Case in point, Julie, is, my son who suffered brain damage from his newborn jaundice in 1995. No one was collecting data on that. The case was not reported to the Joint Commission or any other authority. And what I learned, sadly, is there were several cases before my son, but they were never reported to any learning system, to any authority. The parents signed confidentiality clauses. So this was buried under the radar for almost a decade before Cal was born. Had there been transparency, reporting, open dialogue, had the parents not been, gagged, that would have, would Cal have been harmed? There's so much learning that's buried when we're not transparent. And yeah.
There are two comments in the chat that I want to call everyone's attention to. And one that I think is very important is from Lori Zipperer, who I know has been involved in safety for many decades. And she's talking about the Healthcare Safety Investigation Branch in the UK. Right now, there is a very robust effort in the United States, led by Karen Woke-Feinstein in Pittsburgh and many other organizations and entities to see if there is a way to create a federal health safety board, much like the National Transportation Safety Board. And having participated in many of those meetings about how this might happen, it's been very striking to hear people from the National Transportation Safety Board, because people submit their, I'll call it dirty laundry for lack of a better term right now. And they submit, and when I say people, I'm talking about the airplane manufacturers, the airlines. They submit problems when they arise. And initially, people were very, very concerned about that because they were worried that they would be they would be destroying their competitive advantage in the design of products or whatever. And they very quickly learned how much they learned from one another and how incredibly beneficial that was. So I don't know what is going to happen with this, but it is certainly something that is in play right now that I think could be very beneficial. Some people think that the complexity of healthcare is actually quite different from the complexity of air travel and plane and all the device manufacturing that goes into aircraft. But it's still something that people are looking at that I want to make sure people are aware of. And I also, someone else raised the concept of just cultures, which I also think is incredibly important. And I know in my own hospital, the minute this happened, especially our nursing department, did everything possible to emphasize the rules and the guidelines that we have in play to try to ensure psychological safety in just culture, to try to avoid what Julie and Sue both brought to our attention about the concern that this would bury reports, safety reports, and talking about anything that may have happened. So
oh, I'm sorry.
I think Daniel actually put in something about the role of apology.
Yeah,
I would like both of you all to say something about that. Sue, you want to go first?
Sure. Well, in terms of Vanderbilt and, regaining some trust that has been lost, honestly, I think it's too late for an apology. They've been silent for too long. I think if an apology comes out, at least from my point of view, I don't think it's going to do much for me, but we need to learn from them. But from other organizations, there's a lot they can learn from this case and other cases about apology. Had apology and appropriate actions taken place immediately to the family, to their staff, to their public, I think trust would have been just remarkably catapulted, and elevated. So I hope it's a learning opportunity for other healthcare systems that apology and quick action after harm will, it is the best way to go.
Julie and Sue both, there's a comment that apology admissions are directly linked, founded or unfounded, to liability. Do you want to make
that's a myth. I was
yeah.
I think that in the experiences that we see is that it actually reduces that many people file claims to find out what happened because everything is closed up around them. There are a lot of programs out there that teach apology, but I think they fall short if they're prescribed and scripted An apology has to be real, it has to be genuine, has to be heartfelt, and it isn't coupled necessarily with disclosure. And disclosure is kind of a, well, okay, we said we're sorry, one and done, we disclosed. That isn't how this works. This is a journey and a process that you go on with a patient and their care team over time, because you learn more as time goes on, and more is communicated and more is discovered. And I think we need to get our heads around this idea that when there is harm, it's a one and done, and you move on to something else. That this is an enduring value in an organization that needs nurturing and practice on an ongoing basis.
We have a comment that I think is very important from someone who says, as a mom who lost her child to medication errors, an apology would not have made it better, but it would have been appreciated.
Right.
And I think that's very important and very powerful.
Very well said.
Yeah. And Julie, knowing the roles you've been in organizations, can you say something about the comment from Terry Dashiell about people often say, why penalize people when there are system errors as contributing factors? But in light of what Sue just said, we have to let people know what problems are so they're not repeated. Reporting does not and should not always lead to punishment, but should more often lead to system change, which I think is absolutely critical.
Yeah. Reporting should be celebrated, because that's the raw material for getting better. And if you don't know your vulnerabilities and failure points, you don't know what you don't know. And of course, this should be done before the introduction of new technologies and processes in robust usability testing. But penalties often are very much like a disclosure or policy. You've levied it, and now you move on. And I think there's a need for the ongoing accountability and demonstration of changes that have been made that are effective, so that we are evidence generating about what's going to help to create a safer environment that would prevent this medication error that in fact occurred. And there's always a person in the rubble, and it's a tragedy that often the blame is placed there so that organizations can move on. And that's antithetical to patient safety and trust.
We have one question about, are you all aware of any programs that actually teach telling the truth?
I like that.
You could say a lot about that, but
Yeah.
Sue or Julie, any ideas or organizations that, again, you think do a good job with this?
Kindergarten?
These are kind of fundamental, isn't it?
Yeah, I mean,
Yeah.
this is something that we learn as little ones, and I don't know why it has been normalized in healthcare not to tell the truth. I don't know of any adult classes on truth telling, but I think that's a great question.
I do know that it's introduced as a component in medical school curricula now, in terms of learning about the basics of patient safety. And there are organizations out there such as the Collaboration for Accountability Improvement, MedStar, and others that bring this content into multiple vehicles to reach people. But I don't know it to be a systematic requirement in our healthcare curricula. And that is something I think ought to be influenced.
Yeah.
There's a question that I'm not sure I understand from Nathan Samuels, where there were not charges brought by the family, and this was not related to any cover-up, although I think when sharing the facts, there were a lot of things that were misrepresented on the death certificate, and the lack of reporting to the state or CMS, I personally would call that not being transparent. You know, do we think the attorney would have still gone after this nurse, even if there was disclosure and apology? I'm not sure we know what Vanderbilt's interaction with the patient's family was, and there may have been disclosure and apology. We don't know. I don't know. And that's not something that I think has been discussed publicly.
I believe there was a disclosed, the family has said publicly, they feel like not everything was disclosed to them. And I don't know if there's apology, but it was, you know, they did, Vanderbilt has said publicly, they shared with the family what happened at the time that they knew it, and that then they settled quietly and the family signed a confidentiality clause. But that has been shared publicly on webinars that they told the family. Probably in part what happened.
And Julie, go ahead.
Yeah, I was saying Marty Hadley just posted a great reminder, and that is that ethics training is very widespread, and truth telling is a component of that. And so it doesn't directly link, and maybe we need to start looking at making that more explicit.
Yeah. And I also think I'd like to go back to the psychological safety concept, Julie, because I think that is incredibly important and also incredibly challenging right now when all of our organizations are under siege with lack of staffing, all the impact that the pandemic has had on workforce safety. Anything else you might want to say about psychological safety? And how we help to create that?
When this is when you need it most. In difficult times when there has to be improvisation, teams coming together on the fly, dealing with innovations that have not been in place before, the sense that someone is listening, covering your back, and that leaders are asking questions. This is a time for inquiry-based leadership. It's a different kind of leadership than you see in a stable state. And Amy Edmondson talks about the volatile, uncertain, ambiguous times that we're working in, complex, ambiguous times. And I'm not predicting that that's going to let up. And so we need to find mechanisms to really listen, to be candid, to report without fear of ridicule, rejection, and other ways that are very harmful that prevent people from doing their very best.
Yeah, it's been, I'm reminded of a comment from one of our department chairs from palliative care in the height of the pandemic, when we were struggling to figure out all sorts of things, when families couldn't be with family members who were critically ill and people didn't have healthcare proxies, and you know, everyone was wringing their hands, and she looked at us and said, well, you know, this is my first pandemic. You know, I'm really trying to get my arms wrapped around this, and I think we're still there. In a lot of what we're doing in our healthcare organizations. And there's a comment here that I'd like you both to comment on that I think is really important. In the nursing program I attended, it was heavily pushed to protect yourself from patients, doctors, organizations, because as the nurse, you will always be the fall person, even if you do the right thing. Any thoughts about that? That was something that I am from Tennessee, and I have a lot of relatives who are nurses, and there was a lot of discussion about that when Ms. Vaught was prosecuted for this.
Well, I can take a shot. I find
and
that,
also the role of nursing education in general.
yeah, I find that kind of advice appalling. It's antithetical to team. And to a nurse's self-integrity and the reason you went into nursing to begin with. So those have been things that have concerned me. And while I am a nurse, I have practiced, I've been in advanced practice, And then I've moved into all kinds of other positions. And while the context and the scale has always changed, the threads of integrity, love for your patients, collaboration, and working in a team have always been bedrock. And I do think that there is a dismantling of programs, content that espoused this kind of and prescribed this kind of behavior and set people up immediately to distrust, to fragment, and to not fully engage.
Sue, any thoughts about that? And then I'm going to turn this over to Daniel because I want to give Daniel a
Sure,
few moments
sure.
to talk about the
Well,
ABIM
yeah.
Trust Initiative. But
Well,
go ahead.
I have two things. One is the comment about the nurses protecting themselves from others. Well, it's chilling, to hear it from a patient perspective, that's the reality of the profession that really is aligned to be our advocates to keep us safe. So I think Julie answered that very well. I wanted to go back to psychological safety really quickly. And I really encourage us all as spokespeople for patient safety, that we start talking about psychological safety of the patients and families. I mean, this is a two-sided equation, and that patients and families are often scared to death to speak up about medical errors or to report them. And honestly, as an advocate 20 years ago, we were denied healthcare in my hometown when my husband was sick. People would not treat my family. So there was retaliation on me. We were not safe. We had to get healthcare outside of our. So I think we really need to think globally more about psychological safety when we talk about patients and families and health providers. And so we have a more balanced conversation about that. So I think that's important.
Yeah, here's a vision. It's not difficult to imagine, but it's difficult to get there. And that is when people need and depend on healthcare, that they enter whatever relationship, whatever portal to site of care with a sense of relief. Now I'm where I'm going to be cared for and helped, rather than a tensing up around dread and failure.
Well, I will say from my own experience working around patient and family-centered care, it's almost universal and very chilling when you think that people are afraid that if they even ask too many questions about their own care,
Yes.
not even commenting on things that may be happening that they feel unsafe,
Right.
they are terrified they will be labeled as a difficult patient.
Right. And we are. Yes.
And their care will get worse.
Compromised. Yeah.
And be
You're an
compromised.
engaged partner in your
Yeah.
care. And I think that's a word we need to think about a lot more.
Yes.
How do we partner
Right.
together in care? Because we may know a lot of medical, nursing, physiology stuff, but it's the patient that knows their experience.
Yeah.
And they know their history and they're clear about their values. And if that isn't part of how we're approaching and working with people, we're always going to fall short.
Well, our mission many years ago when I began this work, because many of us had come from clinical backgrounds and had worked in healthcare for decades, was that our dream was that we would have a healthcare system where if anybody we loved or cared about was going anywhere for care, we would not feel absolutely compelled to call whomever we knew there to say, somebody I love is coming in, please take good care of them. We would trust that that was the universal foundation of everything we do. Daniel, I'm going to ask you to help close this out. And I also just want to thank our very engaged audience, and hopefully this case will result in positive things happening in patient safety and in the protection of people that work in healthcare more universally.